Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and let's do this. I have three top amazing superstars in the breathing, sleep, airway field here. It's actually bewildering that I got all of you guys together at once. This is amazing. I'm going to have each of you introduce yourselves, and we'll go over our topic today. Let's start with Dr. Bill Harrell. Can you go ahead and just tell everybody who you are?
Dr. Bill Harrell. I'm an orthodontist in Alexander City, Alabama, which is a little town between Birmingham and Montgomery, Alabama, in the central part of Alabama. And I've been involved with, graduated orthodontics in 1977 from University of Pennsylvania. And then I did a lot with work with Dr. Bill Farah, who was one of the pioneers of TMJ. And then I got in the 80s, got interested in Airway from some of the studies that were done and started looking at early intervention and early treatment and how that affects things. And then the three of us, Nicole and David and Jerry, I've got a book that we're going to be coming out and hopefully the end of this year. And all three of these are doing chapters in that book. So that's something we're looking forward to too.
Thank you so much. And Dr. Simmons, can you introduce yourself?
Yeah, I'm Dr. Gerald Simmons. I'm a neurologist, sleep disorder specialist, also epileptologist. I've been in the field of sleep medicine since 1991 when I was at Stanford University doing my training in sleep medicine after I finished my neurology residency. It was in academics for a while on faculty at UCLA, and then branched out into private practice and moved to Texas. I'm in Houston and have several offices in Houston and one in Austin. I've been real involved in educating and have a nonprofit organization that does educational conferences, been involved in various research aspects of sleep medicine, not just airway, but also narcolepsy and other things that are associated with sleep, parasomnias and things of that nature. But obstructive breathing during sleep is extremely common. And I've watched the field evolve over the years. And I started collaborating with dentists back in the 90s. And I'll talk more about that a little later, but it's been a big influence on my professional development. And I'm real actively involved and work with all three of you. And I'm happy to be here today. Thank you, Nicole.
Thank you so much. And Dr. David McIntosh, can you introduce yourself?
Certainly. So I'm the one with the accent because I come from this place called Australia. And I appreciate the fact that we've lined these time zones up to make this all work because it's always a challenge. I am an ear, nose and throat surgeon, but I particularly focus on sleep disordered breathing, that in children and adults alike. And I was in a weird place in history in Australia because at the time that I did my training, we'd recently had someone that had come from Stanford come and teach us a whole lot of the Stanford protocols that were emerging back in the day. And, a lot of the names that we came to know here in Australia from the USA are exactly the names that you, Bill, and you, Jerry, have actually worked with directly. So, to be in your presence and so forth from that history that you were there as it all turned out as well is just mind-blowing and amazing for me as an individual. And like Jerry, I've been working with dentists for a long time. I thought I was very clever and no one had worked this out, but of course I wasn't very clever. Lots of other people worked this out. We are collectively seeing the same children for very similar reasons with very different perspectives. And Nicole, you've come into the mix now because we've got myofunctional therapy taking, part of the stage as well. So the four of us here really does cover a huge spectrum of this thing that is sleep disordered breathing, especially in pediatrics. So I'm really looking forward to today.
Yes, and we really have a group here to basically cover the upper airway. I feel like we have airway-minded orthodontists, we have a sleep medicine specialist, and we have ear, nose, and throat doctor, all of us with a perspective of airway and breathing, which is not always common for each of our professions. So I'm a speech pathologist, and I also have additional training in oral facial myofunctional therapy. So how the oral and facial muscles affect growth and development of the airway and the occlusion and how that impacts our sleep quality as well. So we really wanted to talk about in this episode the importance of collaboration when treating patients with sleep and airway and other breathing disorders, and also helping parents understand the importance of working with a variety of specialists on these issues. Because when there are airway issues, there really is usually not one simple solution. And I know that we're on various groups on social media and parent groups and different groups where we kind of get a little frustrated or thrown off hearing people maybe being misguided or not getting the full picture when they're talking to various specialists. And it just is kind of upsetting to us. So we wanted to come together to help provide some more answers for parents and other practitioners to help them really see the big picture to get their children the help they need, and not just a narrow-minded perspective from someone who may not have such a holistic training or background in all of these different aspects of the upper airway and sleep and occlusion and issues with occlusion or malocclusion. So what I did want to start out with is having Dr. Simmons explain what a sleep breathing disorder is. What is happening in the upper airway? What's happening to the body when someone is not breathing well during their sleep?
So I want to start off by first reducing the category. You said breathing problems during sleep. We're really referring to obstructive breathing problems. There are other types of breathing problems that can occur during sleep, but we're talking about airway obstruction, and that really falls under this big umbrella of diagnosis that we call obstructive sleep apnea. So let me describe what this really is. Unfortunately, a lot of people have a misconception and think that it's all about oxygen. And if it was all about oxygen, we would call it desaturation apnea, but we don't. It's called obstructive apnea because it's dealing with airway obstruction. So when a person breathes, air rushes through the nose and through the mouth and down through the back of their throat and down into the lungs. As air flows through that space, it creates a vacuum or a negative pressure. That's called the Bernoulli effect. Whenever you have any kind of flow going through any kind of space, you're going to get this Bernoulli effect. An example that most people can relate to would be what occurs in a shower. When you turn the shower on, and as the water flows, the shower curtain will pull in towards the water if it's close enough, because the flow of the water creates the vacuum. And if it's strong enough, it pulls the curtain in. One of the principles of the Bernoulli effect is if you have the same amount of flow, but it's going through a smaller space, you get a stronger vacuum. If you open up the space, you get less of a vacuum. That's why now they have those shower curtains that bow outward. It opens up the space and it decreases the likelihood that the curtain is going to pull in. So these same principles apply in the back of your throat. So when you're breathing, you get a vacuum in the back of your throat. Imagine this being the back of your throat. Imagine this being your tongue. So your tongue attaches to the inside of your chin, goes to the back of your throat and goes forward. So this is your tongue sitting in your airway. So when you breathe, air rushes through the space. When you fall asleep, the muscles relax and the jaw typically falls back. All right. That's true in everybody. But in some people, it's going to fall further back. And it may be because they have a smaller jaw. And they may have extra fatty tissue on the lining of their throat. So they may have enlarged tonsils. There's a variety of factors that will make this airway narrower than it should be. And as a result, there's going to be more of a negative pressure, more of a vacuum that's going to be created in the back of the throat. Now, as the vacuum gets stronger, if there's a lot of tissue in the back of the throat, a lot of what we call redundant tissue, it starts to vibrate under that negative pressure, and that vibration causes a sound that we recognize as snoring. Snoring is a result of the increased negative pressure. It's like getting a piece of paper stuck in your vacuum cleaner that won't go all the way into the vacuum cleaner. So it's to vibrate, making that obnoxious snoring type sound. So just when someone snores, we know that there's an increased degree of negative pressure. As the negative pressure becomes stronger and stronger, and the airway becomes, as the airway becomes narrower and narrower, the negative pressure becomes stronger and stronger. And then at a certain point, the airway can completely collapse. At that point, the person is asleep. They're trying to breathe, but they can't. The brain recognizes that there's a problem, and there'll be a brief awakening. With the awakening, the airway opens up. There's usually a gasping sound, and breathing's reestablished. Once breathing's reestablished, the person goes right back to sleep, and the whole cycle starts over again. So I describe that as a scenario where the airway completely collapses. And with that collapse, there may be a drop in the oxygen that takes place a few seconds later. But there doesn't have to be a drop in the oxygen, but there may be. I mean, you could hold your breath right now for 15 seconds, 20 seconds, 30 seconds. If you had an oxygen probe on your finger, it probably will not drop by holding your breath for 20 to 30 seconds. It takes a longer period of time before the oxygen levels can drop. Anyhow, what I just described is on one end of the spectrum where there's complete blockage. On the other end of the spectrum, let's put normal breathing. So you have to realize that there's a lot of things in between. So there are episodes where there's a partial blockage in the airway where someone's working harder to breathe, all right? And there may be a reduction of flow as a result of that, or maybe they're working harder to make up for the narrowing, and there's going to be enough flow, but it's going to be with some degree of obstruction, overcoming some obstruction. Anyhow, the brain can recognize that the individual is putting more effort into breathing to breathe against that obstruction, and that can trigger a brief awakening or a brief arousal. And as the arousal occurs, the airway opens up, and then breathing's reestablished. So the point to be made here is you don't have to have a complete blockage. You could just have a partial blockage, and your oxygen doesn't need to drop. The significant feature here is that the continuity of sleep is disrupted. So your continuity of sleep can be disrupted where you have these brief little arousals. The person may not have full awakenings. They may not be aware that this is occurring, but it's destroying the continuity of their sleep and lowering the efficiency of what the brain is trying to achieve during sleep. And as a result, there can be consequences during the day. It can be decreased ability to focus, irritability, excessive daytime sleepiness. Hyperactivity can sometimes occur as a way to try to stay stimulated to overcome the excessive sleepiness. And as a result, a lot of kids have been labeled with having ADHD that actually have a sleep disturbance. And out of the different kinds of sleep disturbances, obstructive breathing or obstructive sleep apnea, if you will, is probably the most common thing that could be disrupting their sleep. There are other conditions such as periodic leg movements of sleep and restless leg syndrome, which is also common, not as common as obstructive breathing, but obstructive breathing can be disturbing the continuity of sleep, and it can affect any human being from infancy to elderly and can have a whole host of other conditions. But what's important to really point out for our discussion that's going to continue here is that the upper airway is not a stable part of the anatomy, all right? The mobility that we have in our jaw and our tongue and our throat muscles helps us talk, but we need it to talk and we need it to eat. So the variability and the mobility that we have to allow us to talk and eat makes the airway vulnerable to collapse when we're asleep. So that's sort of the dilemma, because there's so much that takes place with this part of our anatomy, and there's a lot of deficiencies, if you will, that can occur that can hinder the breathing process. And so therefore dentistry clearly is involved, and we're going to talk more about that. Clearly ENTs, ear, nose, and throat specialists are clearly involved. This is where that's their domain, right? I'm a neurologist, and I can't do all of what I do if I don't have good ENT doctors to work with, good dentists to work with, along with other healthcare professionals. But those are key clinicians that I need to collaborate with, and myofunctional therapists become the physical therapist of the upper airway, of the muscles. So clearly, hopefully anyone listening to this is already starting to understand the importance of collaboration, and has also, maybe now you have a better picture of this obstructive breathing during sleep, which people frequently then just call sleep-related breathing problem, but it really is obstructive sleep apnea at various degrees, all the way to where it's of no clinical significance and doesn't exist. So hopefully that sets the stage for the rest of our discussion.
Yeah, that's very clear, very great analogies. And it goes from partial obstruction to full obstruction, which would be an apnea, but simply mouth breathing alone is a problem. Breathing with the mouth open, especially when you lay back and fall asleep, causes the airway to reduce in size, and it could reduce in size by up to 50%. That airway can narrow because that lower jaw and tongue fall back when our muscles relax when we go to sleep. So even simple mouth breathing with no other symptoms is on the spectrum of sleep-related breathing disorders. So what I want to go through with each of our different specialties are what we talked about, things that will narrow the airway that can cause that vacuum when you sleep. So what are things that might narrow the airway? Dr. McIntosh, from an ENT perspective, what might contribute to that vacuum effect and narrowing of the airway?
Yes, certainly. So there's a principle in surgery called the law of the tube. And we use this as a means of really breaking down what can go wrong that interferes with the passage of things through the tube. Now, you can use this in the gut, for example. Why do people get a bowel obstruction? Something that people have heard of. But of course, we're not talking about that end of the territory. We're talking about the airway. So what can cause an airway obstruction if we use this law of the tube, for example? So the law of the tube basically talks about three big things: the inside of the tube, the wall of the tube itself, and the outside of the tube. And if we look at the inside of the tube, that's where ENT comes into the mix, because we've got all these things inside the tube. If we start with the nose, so we have the nasal passages, so the things that can be inside the nasal passages anatomically, that can be a problem. The nasal septum can be deviated. There are structures called the nasal turbinates, which particularly in the process of having nasal allergies, hay fever, become inflamed and swollen. At the back of the nose, we have tissue called adenoids. And then when we jump downstairs, at the back of the throat, we have tonsils. And whilst there's other things in the mix, like the tongue and so forth, they're really the big picture ones from an ENT point of view, especially in the context of children. And given that most of our airway problems start from childhood and show up then later on in adulthood, ways and shapes and forms, that's what I'll sort of focus on there. So if you look at inside the tube, we have those dynamics in play. Then we have the wall of the tube. Now that's where you come into the story, Nicole, because the wall of the tube being a muscle, if it loses its tone, then using Jerry's excellent example, the shower curtain, it's kind of like having a really weak, flimsy shower curtain versus a shower screen. So if you have a shower screen, it's made of plastic or glass, doesn't matter what that shower's doing, that screen's not collapsing in anywhere at all. But if you have a flimsy shower screen, so the equivalent here is the wall of the tube, the muscles have lost their tone, lost their strength for whatever reasons, then that tube becomes flimsy and it's prone to collapsing inwards, regardless of anything else. But then, as Jerry said, we also have to look at the caliber of the space. And this is where Bill starts to come into the story from an orthodontic and jaw point of view, which he'll elaborate some more. But in simple terms, we have a very simple mathematical equation here. And the mathematical equation is that we have the size of the head and the neck, less the soft tissue, gives us the airway. Now, if the bones and jaw structure are deficient, then we've got less space to play with, which means we've got a lesser tube, which means we've got a tube that is more prone to being obstructed. Simply by simple math, if you have a big tube with big adenoids, you might be okay. But if you have a small tube with big adenoids, you're in trouble. And then the adenoids don't need to be as big in someone that has a small tube to be problematic as someone that has a big tube. So all these dynamics come into play. And then continuing with the law of the tube, if we look on the outside of the tube, one of the dynamics that we sort of see certainly in the adult population, which has now crept into the pediatric population, is obesity. And simply by having extra weight that builds up around the neck and elsewhere, we have varying contributing factors. But in simple terms, that can squash in and around the tube and compromise and compress the tube inwards. And that just adds to the problems as well. So this is why you really do need a team, because I can fix the inside of the tube. Bill can help fix the caliber of the tube. Nicole, you can help fix the integrity of the tube. And Jerry, you can tell us if we're doing the right thing or not as we work through it all to make sure that we're actually getting the outcomes that we're trying to achieve, which is effectively to give these children restful, uninterrupted sleep. Because Jerry's absolutely right. We focus on oxygen because we can measure it, so that it becomes low-hanging fruit. But if you're being choked You don't sit there and wait until you pass out from low oxygen. You react. And that's what these kids and adults do. They react. And that's where their sleep gets interrupted. And they have these things which we call arousals, which is exactly that. You are stimulated to respond to the fact that you can't breathe properly. So that's kind of how I'd like people to understand things. And sort of, I know people are trying to find the one thing that fixes all, but when there's multiple things going on, then you need multiple people to help with multiple solutions. So that'd be the gist of it from an ENT point of view.
Yes. And if you're just treating one component of that tube, but not the other aspects, you're not going to get a full resolution. You're not going to get a complete resolution. You might get partial, or you might get relapse. Yeah. So I like to explain it to my patients as 3 interacting systems. So we have the medical system, the dental craniofacial system, or dental skeletal system, and the myofunctional. So myofunctional system being the muscular system, like you talked about, low muscle tone of the tongue, low tongue posture, tongue thrust, open mouth breathing, weak lip muscles, poor chewing patterns, things like that would be in the oral muscular or the myofunctional component. And then in the medical component, we can look at things like you just talked about, Dr. McIntosh, whether it's allergies, congestion, enlarged nasal turbinates, enlarged tonsils, enlarged adenoids, tongue tie, lip tie, things like that can contribute to how the muscles of the mouth work and function. And then in the dental skeletal system, we look at the shape of the mouth and the hard tissue. So how are the jaws aligned? How is the palate? Is the shape wide, or is it narrow and high vaulted? Are the teeth crowded because the jaws aren't large enough? And before I have Dr. Harrell explain that aspect, I just want to say the role of the oral facial muscles in how our airway grows and develops. So we need to have our tongue and lips resting in the correct position from birth, if not during fetal development, which is kind of crazy because they see babies who have a tongue tie when the baby's born. Oftentimes that tongue is already low from resting low in utero, and the baby's born with a narrow gutter palate and oftentimes a more protruded lower jaw. So there's contributing factors genetically that happen really early, even before birth. But what we need is that tongue resting correctly up on the palate, up on the roof of the mouth with gentle suction away from the teeth, but pressing gently on the palate to help the palate grow wide and forward to its genetic potential. So the tongue is like a natural palatal expander, and the lips are like braces for the teeth. And that closed lip posture helps that person obtain correct balance of the oral and facial muscles. And that tongue up helps counterbalance the pressure of the cheek muscles on the teeth at the sides. And we have patients who might be open mouth breathers, or they might just rest with their tongue low or forward or pushing on their teeth. And when that occurs, the pressure from our cheeks, just normally just resting on our teeth on the sides, is no longer counterbalanced by the tongue, and the roof of the mouth can narrow. And the roof of the mouth is the same bone as the floor of the nose. So as the roof of the mouth or the palate narrows, there becomes less space in the nose to breathe, and allergies and inflammation will have more of a significant impact. The septum can bend and deviate because there's less space, and there's this whole cascade of issues that many times can begin with some of these soft tissue problems or tongue and lip problems. So we want to get to the root cause of why a person might be mouth breathing or breathing with their mouth open, why a person might be sitting with their tongue low or forward or spreading wide in the mouth. We want to figure out why that's happening and fix that as part of fixing the whole big picture of these problems. And Dr. Harrell, if you could talk about the dental and the skeletal, the orthodontic aspect of these airway issues.
Yeah, be glad to. Yeah, I think because most people, when you talk about orthodontists, what do you think about? Well, okay, we're going to straighten teeth. And in the world of orthodontics, that's still kind of the main focus, is we're trying to create pretty smiles and pretty faces and things like that. And historically, what's happened is and in the educational system of being trained as an orthodontist, we've tended to wait until these patients have gotten all their permanent teeth in. That's kind of been the normal. Most parents, they go, well, I'm going to go to the orthodontist once all the baby teeth are out. Or maybe they've even been told by their dentist that, we'll send them when they get all their permanent teeth, and then everything's kind of set is the problem. And in the educational system, it's kind of that way. The orthodontist is there for 2 or 3 years to learn how to move teeth. And they may not really get a full impact of what maybe early treatment might encompass. And one of the things that when I teach, I show the picture of a child that's got club feet. And I say, when do you treat a child with club feet? When you see it. As early as you can. It's probably within the same day, maybe the first week, no later than the first month or so. And why do you do that? If you ask Mayo Clinic, if you look on the Mayo Clinic website about club feet, it says, what does it say? You put braces on the legs of their feet to mold their feet to get the major parts of the club feet out of the way. And then you put them in little corrective shoes to try to finely detail. That would be the braces. But maybe you do some things earlier if you put it in the world of the craniofacial region or the facial dental region. What are you doing? You're trying to screen them early. And Jerry can kind of talk about some stuff that we're doing through the American Dental Association as far as trying to screen these children early. The American Association of Orthodontists has kind of at least come to the light of, hey, we need to see kids by 7 years of age for the orthodontic purposes, and maybe look at cross bites and things like that. The problem with it, at 7 years of age, about 85% of growth of the face is already completed. Believe it or not, at 5 years of age, about 50 or 60% of the face is completed. So really early treatment is not really that early. And if we just watchfully wait these kids, which is what happens, a lot of times we'll see them at 6, 7, 8, maybe the orthodontist sees them. Everything looks pretty good. Maybe they've got a little crowding of the front teeth, but maybe they don't have any cross bites. So here's the problem. If there's no cross bite, most of the orthodontists are going to say, well, we can't expand because there's no cross bite. But they're only looking at the dental part, not the skeletal part. Remember, the upper jaw is really not just the upper jaw. It's combined with the whole nasomaxillary complex. And so the nasal part and the maxilla part, which holds the upper teeth, are integrally related. So if you have a narrow upper jaw, what is it going to end up looking like? Well, it's going to have crowded teeth, because you've got a smaller skeletal structure, therefore the teeth are crooked. And the teeth aren't just crooked because they're too big or you've got too many. The main focus is like trying to put a 4-bedroom house on a 2-bedroom foundation. Where's the problem? And here's another thing I bring up when I lecture. It's like having a size 11 foot and trying to put it in a size 8 shoe. Where's the problem? What we've been doing, and I can complain about orthodontist because that's what I am. What we've been doing and what we've been taught to do is we'll take that 11 foot and we'll say, well, it's just too big, so let's cut a bunch of toes off and stick it in the shoe. Well, that's not where the problem's the shoe. Why don't you make the shoe bigger? Now, when can you better do that? You have to do it while they're still growing. It's better to do it in this, what we're talking about now is actually fixed before 6. That's one of the mantras of Candy and Brad Sparks' foundation called the Children's Airway First Foundation. They advocate for fix before 6. And that makes sense because the earlier you can do, there are even people out there, Kevin Boyd and some others, that are treating even earlier than that at 3 or 4. I do have some actual 3 and 4-year-olds that have been diagnosed with sleep apnea. And so what do? We get in, if they have some craniofacial form issues, we're going to go in and try to create more space. It's like Jerry said with the shower curtain. I'm trying to bow out that shower curtain so that the air flows better. So you've got to get in there early. You've got to do some diagnosis. This is where 3D imaging comes in. We do use cone beam CT. It's very low dose now, but it tells you so much more information that you can get. Many orthodontists still use 2-dimensional imaging. And if you're using 2-dimensional imaging, trying to figure out a 3-dimensional object, you don't get very close. Your anatomical truth is not there. And that's what cone beam CT allows us. It doesn't diagnose the problem of airway, but I can tell if a patient's got a very narrow upright and awake airway, they more than likely got a pretty small airway when they lay down and go to sleep. So at least it puts me in the ballpark. But you have to do other things. And one of the things that we are actually doing now is we're looking at nasal testing and nasal resistance and things like that and measuring that. And it's interesting to see when you start looking at maybe some nasal resistance is causing patients to mouth breathe more, and you go in there and do some expansion and find out that, hey, it is affecting. It's like Dr. Christian Guilleminault, who's the discoverer of sleep apnea back at Stanford, who Jerry worked with intimately there at Stanford, said, you've got to get the child nasal breathing. If you don't, you have not fixed their problem. So that's the things that we need to look at as orthodontists, is really look beyond the teeth. I wrote an article called The Breathing Smile Connection. And the book that we're coming out with, that we've all got chapters in, is called Sleep, Craniofacial Form, and Airway Function Disorders. And one of our main editors there is David Ghazal. He's the dean of the medical school at Marshall and one of the most prolific authors in the world now on sleep apnea. David McIntosh is one of the other co-editors. Jerry's doing a chapter, and Nicole's doing some chapters on myofunctional therapy. And so it's really about collaboration too. That's what we're talking about here. And I've got 2 cardiologists that are giving chapters. I've got, of course, Jerry is a neurologist. I've got Stanley Liu, who's used to be at Stanford, now he's at Nova, who's an otolaryngologist. So we have a lot of medical. This book was written for a reason, to be heavily weighted toward the medical side and then to bring in the dental. So that's kind of a little bit of what we've been doing.
Yeah, and I think that's great how you talked about the shoe analogy, because it relates directly to Dr. Simmons' analogy and Dr. McIntosh talking about the tube or the airway. The smaller the airway, the smaller the shoe, the more vacuum is going to happen. So we want to treat the issue by enlarging the shoe, enlarging the airway, making the tube bigger. It's almost like those cardboard straws. When you think of, do we want a small skinny straw that's made out of cardboard, or do we want a large, like a boba straw, a wide straw with hard sides, solid sides? So we want muscle strong, we want airway open and wide, our breathing tube wide and open to help prevent that vacuum, which will help prevent that brain from waking up as it's choking. Dr. Simmons, you want to say something?
Okay, so we've characterized this breathing problem. All of us have contributed to this well architected out scenario. And those that are listening to this are thinking, yeah, oh, this all makes sense. But what if I put out there for those that are watching this to let them know that this is not taught in medical school? This is not taught in dental school. I didn't learn this until I was doing my fellowship in sleep medicine, after I'd already gone through medical school, an internship, and neurology residency. Then I learned some of what now I refer to as the basics of breathing physiology and how it relates to sleep and disruptions of sleep. And it's mind-boggling how such a simple concept of the anatomy and how it changes when you're asleep, of the airway, and the influence that it has on disease development and other medical conditions. So there's a real problem, because we try to get this information into medical training, into dental training, and you'd think that they would take it with welcome arms. They don't. And there's a lot of just social, economic reasons why that doesn't happen, because everyone's got their own agenda and everyone sees the world from their own perspective. And we obviously have a perspective that's not in a silo. It's a collaborative perspective. We're different healthcare professionals and we're all coming to the same conclusion. And you would think that the medical schools would just grab onto it, but it's unfortunate. So anyone that watches this, if they have any influence with anyone that's at any kind of a healthcare educational program, let them watch this video, pass it on, because this information can't be put on the sideline. This is important stuff, and this will change our future generations. If we can get the current individuals that are going through training in healthcare, then it will change the next generation of clinicians. But we currently have a whole field of clinicians that never had this training. And so one of the things that I've been working on is trying to fill this gap of knowledge. And I'm only one individual, but I put together a conference that we hold every year. The Sleep Education Consortium is the nonprofit organization. And we have a conference on sleep disorders. It's several days long for physicians and dentists and myofunctional therapists and other healthcare professionals to bring them up to speed. Because it's like, if someone's interested, where do they go to get this information? Well, that's part of the problem. But there's a real deficiency. So if any of you watching this try to validate what we're saying by bringing it to your primary care doctor and say, oh, I heard this stuff on the internet, what do you think? You're probably going to get a response that's not that supportive of what we're telling you. And you shouldn't get dissuaded and think, well, your primary care doctor has the right answer and we're the ones that are off the wall. No, it's the other way around. Just ask your primary care doctor, how much training have you had on sleep disorders? Was there much covered before? Did you know that oxygen doesn't need to drop to have sleep apnea? They'll probably say, what? I haven't heard that. No, it's all about oxygen.
It's even the same. Other sleep doctors don't know about this. Other orthodontists, other ENT doctors, other dentists, pediatricians, they don't know.
Part of the reason why they know, but they don't really remember or they don't really acknowledge. Because Medicare does not there's different ways of scoring these hypopnea events, the hypopnea, the partial blockages. And, obviously I was fortunate enough to be introduced to this field by one of the great formulators of the field, and Christian Guilleminot. And he taught me early on that it's not about oxygen. But unfortunately, a lot of people think it is. And Medicare, when the scoring rules finally changed in 2013, and these more subtle hypopneas were being recognized to be worthy of tabulation, there was so much disruption within the field and a lot of pushback because Medicare didn't recognize that. Medicare had their definition of what a hypopnea was, and that definition said that the oxygen had to drop by 4 percentage points, which I jokingly say, when God created man, God said your oxygen has to drop by 4% or else it's totally okay. I mean, I'm being facetious. It's not true, but that's almost the dogma that people take when and Medicare, they only acknowledge the hypopneas have a 4% desaturation. So a lot of the other doctors say, well, since Medicare doesn't recognize it, I don't even score those. How ridiculous. You're trying to diagnose a patient with a problem and you're going to limit your skill set because Medicare is naive and they're not sleep specialists and they don't recognize these non-desaturating events. Therefore, your patient's going to get the wrong diagnosis. Nowadays, most private insurances will recognize these more subtle events. They're not holding by the Medicare criteria. But yet, again, a lot of physicians are naive. And then they're going to use a home sleep test as though it is just as good as an in-lab sleep test. And when the home sleep test, which relies heavily on the oxygen aspect of the condition, when it comes back as normal, they say, oh, you don't have a problem. How ridiculous. A home study is not as sensitive as an in-lab study that's scored with the newer scoring criteria. So if a home study is negative and the person has symptoms, they have to go into the lab and they have to make sure that it's a lab that uses the 1A scoring criteria for hypopneas.
So I think we'll need to get into a little more detail with some of the terms so parents can understand if they're not familiar with terms like hypopnea and but what I do want to say is how many parents have taken their children to a sleep doctor and maybe their child was put on a CPAP or said, why don't you wait, they'll outgrow it. How many of those parents were also told, go see an ENT to have enlarged tonsils, enlarged adenoids ruled out, to check your airway? How many of those parents were also told by the same provider to go to a myofunctional therapist to investigate the low tongue posture, the tongue thrust, the open mouth breathing, and also told to go to an airway-minded dentist or orthodontist to help grow the palate and widen the jaws because the mouth is narrow and the teeth are crowded? I don't think many practitioners are noticing all of these aspects and referring parents and patients to multiple providers. It seems like when I look at some of these social media groups, there's been one treatment. Maybe it's been, oh, my child had their tonsils and adenoids removed, but they're still snoring, or they're still waking up at night, or they're still really moody. What do? They weren't referred to all of the providers necessary on the team to treat these issues. And I see a lot of these kids are put on CPAP but have they been referred to ENT and other aspects? So when we're talking about collaboration, there are multiple people on the team the child must see to rule out problems in all of these domains, because typically there are components in all of these aspects. The dental aspects, medical aspects must be treated, and muscular aspects of the oral facial system. So I want to ask you guys, who are the collaborators or the providers that you work with? Clearly, we say airway orthodontists, airway specialized ENT doctors, sleep doctors, anybody else on the team. I would say these are like the primary practitioners and the myofunctional therapists. Anybody else?
Well, insomnia is an extremely common condition, and it has more than one presentation. There's sleep initiation insomnia where you can't fall asleep, and then the sleep maintenance insomnia where you can't stay asleep. But if a person's lying in bed and they can't sleep, and a lot of times their mind won't shut down, they need a different type of treatment that we haven't touched on here, nor do we really have time to. And in our clinic, we would just take that up head on. But in other scenarios, if the clinician recognizes the issue, but they themselves aren't really focused on treating it, then referring on to, let's say, a psychologist that also has training in what we call behavioral medicine, and they can help with the insomnia component of the patient's sleep issues.
And Dr. McIntosh?
Yeah, so I just a few little reflection note just for those that tune in, because you have a fantastic worldwide audience, Nicole. So we also have Medicare as a term in Australia, but it does not mean the same thing as the USA. So just to make sure that we're not conflating healthcare systems, even though the word is the same. But I would certainly back up what Jerry said about the way that we look at these sleep studies. There needs to be a standard in terms of how they're interpreted, but there also needs to be a standard in terms of how they're implemented, because we've used some terminology. So we use sleep apnea. So if we break the etymology of that word down, nea means breath and a means without. So even though we say apnea in English, it's technically anea, we sort of to use the Greek, but it means without breath. Hypopnea, hypo means less breath. But we can run into scenarios where the way that we measure these things doesn't fully capture all of the data. So, for example, as Jerry said, you can have a situation where the airway is partly blocked, but that person can overcome that blockage by working harder to breathe. So on paper, it looks like that person is breathing okay because you're not measuring the breathing effort. And this is where Jerry's lab in the USA stands out far amongst the crowd, because they do use the esophageal manometry, the measurements of the pressure inside the chest as they breathe, which gives you an indication of how hard are they breathing to maintain their numbers. And then you sort of go down the line to home studies, and then you go down to the watches, and then you go down just to the phone apps. And as we move down that line, the accuracy really starts to deviate significantly. But look, not everyone has access to top lab in-hospital facilities, so we accept these compromises, but recognize they are what they are at the time. To recircle back to your question, so look, if we were to look at the big picture here, if we look at the majority of children that we are talking about, then yeah, we are going to pretty much cover most children if we have a sleep doctor, an ENT, airway-focused dentist/orthodontist, and a myofunctional therapist. The four people in the room right now, collectively, we would pretty much be able to sort out most children, but most children is not all children. So where do these kids fall off? Well, one of the ways they fall off is with allergy. So I definitely have an allergy doc as part of my team, because I can get these kids out of trouble, but we've got to keep them out of trouble.
That's
so I think that's very important.
Allergy doctor was what I was going to add on. Yep, perfect.
Yep. Some of these kids have gut issues as well. So sometimes we have gastroenterologists involved to manage that side of things. They can have other underlying conditions, generalized poor muscle tone. So this is where they might end up, say, with a physical therapist of some sort to address the overall elements, not just their specific throat elements. Jerry mentioned a psychologist. One thing I think it's really important for parents to realize, because I have the parents come in, you know, I say, look, any other health problems? And they say, oh, my child has anxiety, but I know it's got nothing to do with it. And I'm like, back up the truck here. We know that mental health problems manifest much higher in children and adults alike if they have airway obstruction. And anxiety is definitely on that list. So is depression. So is, as Jerry said, ADHD. You know, we've got a problem here where, you know, kids fronting up to an ADHD clinic are going to get an ADHD diagnosis, but No one's asked why. And you go asking the why, and then you start asking the questions about breathing and sleep. And then, the group of us in the room fix these kids, and we look at these kids 12 months later and they no longer have ADHD. Well, there's no surgery, there's no orthodontics, there's no myofunctional therapy that cures ADHD. It wasn't ADHD. It was obstructive sleep disorder breathing. So we really got to change the narrative. And Jerry's absolutely right in terms of the education. Now, I don't hold anybody to fault. If you see your family doctor and they don't know about this, I don't hold them to fault, because you can only know what you've been exposed to from your education. And your education initially comes at university, and then it comes with continuing professional education. But as we know, medicine is an enormous expanding subject and topic. I would hate to think how many new drugs come onto the scene every week, month, and year that the family doctor has to try and keep tabs on in terms of what they do and who they're indicated for and so forth, let alone what we're talking about. So I think one of the things you said, Nicole, which might have slipped past people, but it's really important, is that it's got to be clinicians in this area that are actually focused on this area. It's very easy to see an ENT. It's very easy to see an orthodontist. It's very easy, etc. But unless they actually specifically focus on this and have in-depth knowledge and know what they can and can't fix. Because when I grew up and taught ENT, I was told with these kids, we take out their tonsils and adenoids and they're fixed forever, completely, all the time. That's what we had to play with. And it's wrong. And I know it's wrong, but I didn't know it was wrong. And I didn't know it was wrong for a while. So when you get new information, you get new knowledge, then you've got to have new perspectives. And that's where, like Jerry, with me sort of, being a medically trained person with no dental skills, no dental knowledge, don't ask me about teeth. I don't know anything about them, even though I look at them every day in passing because I'm looking inside the mouth. It's a woeful reflection of our education system, really. It was the dentist that changed my perspective on this, because they're the ones bashing their heads against the walls going, these kids have got jaw problems. You guys, you're not sorting out the jaw problems. And then we have people like yourself, Nicole, that go, you're not sorting out muscular problems. And then we have, as Jerry here doing a fantastic advocacy for education, just in terms of the systems, because I know Jerry has sort of had to fight against the system to say, you guys have got to score these things properly. We can't be guided by, as you said, Medicare determining what it thinks is right when the science shows that it's wrong. So having clinicians that are actually tuned and dialed into this is actually a really important part of the dynamic as well.
Yeah. And as we wrap up the last couple minutes, I just want to bring it back to the beginning. And I know this is going to be multiple parts. So if I can get you gentlemen back on again for like 10, 20 more times, I have a lot of questions. I think we should directly target some questions that I see on social media in the next episode to really directly answer questions parents are asking, like, are there natural ways to reduce or shrink the size of adenoids? What about central sleep apneas? Are those normal? How do you treat those? Is it normal to put a child on a CPAP? Are there other alternatives? Things like that. So we're going to get to that the next time we meet. But I just want to ask, to bring it back to the beginning, when Dr. Simmons talked about the brain arousals from that smaller breathing tube. And when we're working harder to breathe, the brain says, oh, you're choking, and the brain arouses. How can parents notice these brain arousals in their child? Now, we can see it on a sleep study when there's EEGs, but what would a parent see while their child's sleeping?
So with the 1 or 2 minutes that there may be left, let me address a couple of things real briefly. We can go more detail, but just for anyone watching this and investing time to get this far into the video, and you've mentioned certain questions, I don't want them having to feel disappointed and hanging. You can use CPAP in a child, but it should be thought of as a transitional therapy, not long-term for the rest of their life. Use it so they can get better sleep while they're undergoing other structural enhancement maneuvers, whether it's surgical, whether it's going to be orthodontic or what have you. So think of it as a transitional therapy. Sometimes the child has to come into the lab to figure out the right settings. And if they're having problems with it and the clinician doesn't bring them into the lab, then it's a suboptimal implementation of CPAP. So children can't do well, and don't worry about the change just causing all sorts of disconfiguration of the face, because it's a temporary management, but you're also expanding while they're also wearing it. And the mask shouldn't have to be put on tight. If it's being put on really tight, it's because there's not good hygiene, cleaning the cushions properly, and there's oils to make it more prone to leakage. So you're strapping it tight to overcome the leak. Anyhow, and then the other thing you had mentioned.
And it's okay to leave people hanging a little bit, because then they'll stay tuned for the next episode, because we will have more time to answer. I know you all have other meetings immediately after this and other patients. You guys are all so busy that I'm so gracious that you squeezed in an hour to go over these things, but we will take a lot more time to get into more detail about these specific questions the next time.
I'd like to make one plea at the end. I hope everybody's held on to this last end, but yesterday they had all 4 of the Make America Healthy Again doctors that they were interviewing on Fox News. And this is not just a America problem, it's a worldwide problem. So it may ought to be MWHA, but anyway, Make America Healthy Again. And that's, Dr. Oz and RFK Jr., but I would make a plea to some people out there that may know how to get in touch with them. I listened to the 4 of them talking yesterday, and all the questions were about nutrition and taking dyes out and all this other, and exercise, and all that's great. But where does it start? The thing that they're missing and they need to make sure they have on the agenda: breathing, then nutrition, because this is the way it goes. Breathe. You got to breathe first, nutrition, sleep, and exercise. And a lot more to it than that. But I'm just saying, because they talked a lot about ADHD. And Robert Kennedy Jr. said, we're going to get to the bottom of why these kids have it. But they're taking that into consideration. So I'm hoping. I've already got in touch with my 2 senators and others, but we need some worldwide connection here. But I think if we could get in front of HHS and at least make that the Make America Healthy Again agenda, is breathing, nutrition, sleep, and exercise.
Yeah, no, that's a great point. And we'll talk about in another episode the consequences of fragmented sleep. But when we keep mentioning ADHD, the big picture is children who are sleep deprived or not sleeping well tend to become hyperactive in response to that poor sleep quality. Whereas adults, oftentimes we just get tired, we want to take naps. Some adults might fall asleep while driving, things like that. The majority of children actually become hyperactive, or we might say tired and wired. So that's where the ADHD plays a role with the poor sleep quality. And I thank you all for being here, because I know you all have your next meetings and patients right now. So we'll meet again to go over more details. Thank you so much for helping everyone in the community.
Thank you,
Really
Nicole.
Great pleasure as always with you all.
Thank you, doctors. Thanks.
Bye-bye.
Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.